Now we are opening for question answers. So if any of the participants have any question or clarifications with any of our speakers, please raise your hand. Muskan?
Muskan, she's a deaf person. If you can spotlight her, I could see her signs. Yeah, it's better now. So Muskan is a deaf woman. She is asking, related to the autism, we do have deaf people as well who are autistic as well. So sometimes we try to make them understand, but they people try to make the courses available for them. They might be in more artistic way. So could you share some, I mean, the other approaches if they want to learn any particular things, if not just the teaching way, what the other ways we can use to teach them particular things?
Yeah, well, mainly with autism, with 40 to 60% being nonverbal. So we look for an alternative communication system. They don't learn sign language as well as people with hearing impairment. And, like spelling and using, but they use something called the Macoton signs. Okay, Macoton signs are like, I want to eat, I want to drink, want to sleep, let's go for a walk, we're in the car. There are signs which are more descriptive than they are a language. So sign language is a language. But the need is there for communication. They could be missing on some of the input that what's going on, because with the hearing, they have, most of them, hyper hearing. So what they do is that they close the hearing. A lot of time parents, they don't have to close it with their hands, but their brain tells their ears, I do not want to be hearing now because it's causing me pain. So a lot of parents tell us, I call him and he doesn't answer. Although he would hear like the sound of a bag of food that he likes, like chipsy, for example. He will hear it and he'll be there in a minute to get it. So this is because the sound of chipsy is a friendly sound to him, which he is okay to hear. But there might be other sounds around that. So working with people with autism, we have to work on the communication. I don't know if I answered your question, Muskan, because I got a bit lost when the signs were not clear and your interpreter, Manisha, was not able to tell us. Did I answer you? Please let me know if I didn't.
Yeah, I do understand. I understand that the communication is a need, but it's better, if they know the sign language, that is more helpful for them. But I just want to know what would be the methodology to teach them anything.
Like everybody, they
Just a
learn
second, I think she
from.
hasn't completed her question.
Yes, okay, I'm sorry.
So, for example, if you want to share the moral stories with them, right? So, how we can have them in an inclusive manner, right? So, what would be the right approach to tell them? I want them to grow, I want to be connected with them. But is it easier to, I mean, share the moral stories with them, or is there should be any particular approaches to deal with them? That each
Okay,
wants.
with autism, the social side of communication is not there. So there's something called the theory of mind, where they cannot put themselves in your place. So if you tell them a story and they can't put themselves in the place of whom you're talking about and understand, like, oh, mommy hit her arm, so mommy's in pain. No, they can't understand. Sometimes if I hit my arm, my son will laugh. To him, this is something out of the ordinary and it's funny. But we work on this. We work on feelings. We work on them understanding the others and work on them naming feelings. So that in time, when they've learned that, you can then go into the part of stories. In the beginning, we use stories called social stories, which are just about teaching them about the rituals that happen every day. Like if we say Ali will get ready for school, so Ali gets up, we'll put a picture of Ali, and Ali gets up, getting out of bed. And then we say Ali will brush his teeth, then we'll put a picture of Ali brushing his teeth. So we use picture and the sentence. Not all of them will be reading, but that's the kind of stories we create called social stories, which we use with them so that it's something that they experience and they can understand. It is, you relate it to what goes around in their environment. In time,
Thank you.
you can then upgrade. Okay?
Yeah, I think this requires a long conversation. If Muskan is okay, she can also talk to Dr. Helali through email.
Yes, I can
to
send
get a lot
her
more
something
clarity.
to eat.
Yeah, Sheila George, to ask your question. Sheila George.
Yeah. My question is actually for Dr. Diwan. I appreciate that you have been training ASHA workers. I think that includes Delhi as well. My question is, ASHA workers are given incentives to do their jobs. Right now, they get incentives for TB. That's how they work. I understand there's no incentive for identifying disabilities in the community. So after having trained them, so how is this going to work out that ASHA workers do identify as well as work with persons with disability in the community?
So thanks. That's a great question. Thanks, Sheila. So I think, the important difference between, I think, the two other presenters and myself is that we are a public health research organization. So we're trying to generate evidence at this point. So in the projects and the programs, we are working with two kinds of workers, ASHAs and Anganwadi. So in the new project, we will be working with Anganwadi workers also who are salaried. And of course, like all frontline workers, at least in the context of India, every new program ends up on their heads. So, but what we are trying to show through the process of our research is that it is possible and it can be done effectively and efficiently. And I think then the aim is to go to policy and generate an incentive for detection and incentive for intervention for ASHA workers, and to recognize, say, an Anganwadi worker to be a specialist worker. So the idea is really to show models that are possible and then leverage policy to actually start working towards, a larger scale up. So we are really not scaling up services, but we're trying to generate the evidence, if that makes sense.
Okay, thank you.
Sue Enfield, you can go next. Your question.
I wanted to ask, I'm not quite sure who might like to answer this question, possibly the lady from Sangat, but I work a lot in Rwanda and there is a good understanding of the social model of disability, but there's also a certain faction that is quite medically oriented. And in listening to you all speaking about diagnosis, I'm struck by the fact that the work that you're doing deals with the consequences of the condition. And I wanted to ask in general whether you feel, especially when you're working through non-specialist workers and through parents, it's satisfactory to just address the consequences, and it's not so important to have a specific labeling of the condition, because if the outcomes and consequences for the family are the same, Does that really matter? Or is that too much of a sort of generalist's view? Thank you.
So I'm just happy to attempt to answer that quite complex question, and then maybe hand it over to my co-panelists. I think you're right. I think there is, social determinants of diseases are very important. I think the other thing that we're trying to do in the new program that we are trying to address is what we call a trans-diagnostic approach. So is it possible when you detect, because one of the big roadblocks in for many families is actually getting a diagnosis. And I would say this is across low resource settings. We see this actually all over the world. And I'm not sure I got your accent right, but I know that even in countries like UK, in the US, there are long waiting lists to get a diagnosis. So in the current work that we want to do, which is the detection care pathway, what we're trying to develop is a journey map for families where the moment there is faltering development, a frontline worker is trained to recognize the change or the faltering development and put the parent on the right track. So, of course, as we know, hearing impairment, visual impairment, they need biomedical approaches. It's very hard to do things psychosocially for sensory and motor problems. But with autism, with things like ADHD, with things like intellectual disability, where you may not have medical comorbidities, it's very possible that you could give them broad-based interventions. And so one of the broad-based interventions is called the WHO, the World Health Organization has developed something called the caregiver skills training, which is really focused on getting, it's kind of a psychoeducation package and giving parents a broad set of skills to understand their child. So that is kind of a very good starting block. And if the child then has social communication problems, so we're not even going to call it autism in the new program, we're going to say that your child has social communication problems, why don't we give you something called PASS Plus? So I think increasingly we will need to, particularly in a CBR or a community-based approach, really have the diagnosis as something which potentially could happen on the side. I also want to just add a small caveat, which is I think diagnoses are very important for receiving services in many contexts. So in the UK, in the US, you will not be triaged into services unless you have a diagnosis. In many low resource settings like India, there are very few services. So often the diagnosis is not so important, but there are disability cards, there are disability, there is a disability certification, all of which become important to get certain kinds of benefits. So I think it's a fine line between the two. And so I'm not quite sure whether I've answered the question, but certainly I would say early interventions should start off anyway, whether you have a diagnosis or not.
Although I'm not a panelist, it makes common sense for me that one thing is, the first thing is we should not get fixed on models, the social model, medical model, whatever model. The thing is whether the need of the child is it being addressed in a holistic way. Therefore, I think that if you have that setup, that frame of mind, then with the way you approach the situation will be completely different than from when we get into fixed models of intervention. I'm not saying one social model is to be done away with. I'm not saying that at all. But we need to recognize the situation of the need of the child or the individual and address. And the medical model has its place. So to say that only social model should exist, not the medical model, would be doing a grave injustice to people with disabilities, me being one. Thank you.
Rajul, you can ask your question.
I have a very simple question, and I think the person from Egypt did answer it in part. Is AAC used at all in any of the intervention system? Because it wasn't mentioned at all. And in the past project, in the past pack project, does AAC figure at all? AAC meaning alternative communication methods?
No, we are not using alternative communication methods at all, partly because these children, first of all, are quite young. They are 2 to 7 or 2 to 9, and we haven't really, thought about that at this point. I'm sure there is a place for that as children grow, but not at this point. We're really aiming at this point to develop social communication in these young kids. So the answer is no. I just want to answer one thing is I really do want to clarify that I represent something which is very different from the other two people who are delivering services. What we are trying to do is generate models and evidence for evidence-based interventions. So in the real world, you might put together a number of things, and hopefully all those things have good evidence supporting them. What we're trying to do at the moment is generate evidence for a social communication intervention.
Intervention from Dr. Helali, Dr. Maha Helali.
Yeah, I just want to add that
Respond to
yes,
that.
Rajul, we use the alternative communication system because what can we do when 40 to 60% are nonverbal? And if we just keep pushing and pushing and pushing that the child talks and he doesn't talk, the parents get very depressed and frustrated, and we want them to go on and we want the child to communicate and tell us what he's feeling, what he wants, so that the behaviors are more controlled. Because a lot of the behaviors are there to tell us that they're not happy with what's going on, or they're not able to get what they want, or they're not able to express. So you need to give them a method to express. So whenever we use language, whenever we use alternative communication system, we have to use language with it. So this is the main thing. If you're going to use a photo for communicating, the picture exchange, you have to use language with it. Sometimes we find the kids starting to talk, This will go on besides also the speech and language therapist working on all the oral motor skills. We do not give up that the child can talk. I had a child who started talking at 11, and they usually taught us that after 5, if the child never talked, he will not talk. No, we had a girl talked at 8. We had a boy who talked at 11. So we never stop. We do the alternative communication because he needs to communicate what he's feeling, what he wants. This helps us, of course, to start teaching academics. And then it also helps with the everyday life. Even with the sports, we are using photos with the sports so that it's a visual aid for them. And even with those who are using language, they like the social stories. Those who are reading and writing, they like the social stories. It's something that makes sense to them.
Now I request Snigdha to give the vote of thanks.
Thank you, Meenakshi. On behalf of the Indian Disability Forum, IDF, and Indian Forum for Rehabilitation and Assistive Technology, IFRA, I thank our 3 presenters today, Dr. Gauri Diwan, Dr. Maha Helali, and Mr. Thakur Prasad Chapagain for their eye-opening and beautiful presentations. We thank the event aid agencies, governments, civil society organizations of persons with disabilities, parents group representatives, and academicians for being with us today. We also thank the translators, Ms. Nidhi Agarwal, Ms. Yanike Hansen, Ms. Firoza Hosania. We thank the sign language interpreters, Ms. Manisha Sharma, Mr. Atul Kumar, Mr. Manan Sharma, and Mr. Deepak Shashtri. We also acknowledge and thank the participants for their valuable contributions. Our thanks go to Ms. Ramachari, Disability Rights India Foundation, Mr. Arman Ali, National Center for the Promotion of Employment of Disabled People, Ms. Tulika Das, Gautam Chaudhary Memorial Fund, and Ms. Radhika Alkaji for meeting the cost of sign language interpretation, Hindi translation, and documentation. Thank you, Mr. John D'Souza, of Center for Education and Documentation, and Ms. Poonam Natarajana Vidyasagar for the digital documentation and technical support for the webinar respectively. Now at the end, may we observe a minute's silence in solidarity with those people with autism who need support.